I'm Susan Goldstein. I'm a family doctor here in Canada from Toronto. It is my honor and my pleasure to moderate the session for you today and to introduce you to our two outstanding speakers. They are both Canadian. First is Dr. Elaine Jolly, who's an OB-GYN from the University of Ottawa and a founding member of the Canadian Menopause Society, also known as SIGMA. I will speak louder, okay. And Dr. Michel Fortier from the University of Laval, also an OB-GYN, also founding member of SIGMA, the Canadian Menopause Society is our new name. Dr. Jolly is also one of the board members at the International Menopause Society. But what sets them apart is their passion and interest in women's health, and particularly immature women's health. You're in for a treat today. We are going to take questions at the end. So we'll go through our two presentations, and we should have lots of time for questions after that. Thank you. Dr. Fortier.
Okay, thank you, Sue. So it's my pleasure to be here this morning, and we'll try to entertain on the transdermal menopausal hormone therapy. That's the goal of this symposium. We have an hour and a half, so we have plenty of time. I'll give a little presentation, plenary, and then Elaine, my colleague that I've been working for so many years with, will give some cases, discuss with you, and we'll try to improve our knowledge on all that stuff. So the title that we managed was the Transdermal MHT Key Issues, 16 years post-WHI. What has transpired? Statistics, research, guidelines, oh my. In French, I don't know what means oh my, but Elaine put that on, so I left it. So conflict of interest, you've seen it so many times now. Now, the funny thing for some of you, because we're all young, but we were in the IMS World Congress in 2002. Dr. Graziani was the president at that time. So it was in Berlin, Germany. And at that symposium, we were learning a lot of hormones, everything, but nothing transpired about the WHI study. We were going on with that nice study. Everybody was happy. And we had meetings, reception, wine and cheese, everything. Nobody was talking. But about 12 days, 15 days after this interesting meeting, the Y results came out without anybody having talked about it before. So it made an earthquake and tsunami. You've seen the perfect storm on the previous room. So the earthquake and tsunami was provoked by the results of the WHI. So you've learned a lot about it, but there were two studies going on, one for the patients with the uterus. They were using CE and MPA, and the Safety Monitoring Board stopped this arm in May 2002 after 5.2 years of follow-up, which was short for that study. And their conclusion of the paper, and that's what we see from Rousseau writing in the JAMA in 2002, was that overall the health risks exceeded the benefits among healthy postmenopausal US women. They didn't specify the age of the women, but that was the conclusion. All-cause mortality was not affected during the trial. Risk-benefit profile is not consistent for primary prevention of chronic diseases. The results indicate that this regimen should not be initiated or continued for primary prevention of coronary heart disease. We're not talking about breast, we're talking about prevention of coronary heart disease. Do not use HT to prevent chronic disorders in asymptomatic menopausal women. So that's the group of patients that we were talking. You all know these statistics, but just on the written in red, these are the absolute numbers that we tell the patients, you know, as far as breast cancer. As Bob said previously, there's 26% increase in risk of breast cancer, but when we ask the patient, it's not the number of cases, it's the risk. So what is the risk? The risk was 8 attributable cases per 10,000 women per year. So that made this tsunami, and that make all women stop the HT because the news were just insisting on this particular issue. So women, even if they had no uterus and they had not this product going on, they were stopping. So in February 2004, so 2 years later, the NIH ended the CE arm, and their conclusion was that the use of CE increases the risk of stroke. Again, the newspaper didn't have food for their paper for breast cancer, but they had food for the risk of stroke. So they insisted on the risk of stroke in women, but the risk was mainly in older women, not in younger women, the one who we addressed this situation in early menopausal status. So it decreases the risk of hip fracture. These were good data. And there was a possible reduction in breast cancer. Nobody knew about it. It was surprising, but that was really reassuring for those patients. And the conclusion was CE should not be recommended again for chronic disease prevention in postmenopausal women. The risk there were the same, that if we address the attributed risk at women entry, we had 12 per 10,000 women year for the stroke, a little bit of VTE, pulmonary embolism, and there was a reduction again in hip fractures and total fractures. So these were the RIP. What happened next? What happened? Women stopped using HT. Many menopausal women remained very symptomatic because menopause is still ongoing. It's been there for years. It's going to be there even after I passed away. So the increased use of antidepressants, we've seen this slide by Bob Reed, increased osteoporosis fracture rates, and the healthcare providers became hesitant to recommend HT. Because of the lack of knowledge, because of the lack of manipulating the statistic and explaining to our patients, and also because the situation was that women were afraid of hormones. The management of menopause became a subject almost eliminated from curriculum at university level all over the world. I mean, even of our own university, our people, they don't learn much about the products, the way to deal with menopausal symptoms, how to address these issues. And more than a generation of young doctors have lost the ability to prescribe HT. So we've seen on that slide the decline use that appear with hormone therapy just starting from 2002 going up to, we could say now. So there's a significant decrease. And I show again this slide that Bob showed you, the simultaneous increase in prescriptions of SSRI after the WHI. So we see on the green curve the increase in SSRI use among women and the decrease in HT among women. We cannot say that it's directly the consequence of this stopping of HT, because at that moment also the industry, they started to promote SSRI among physicians to do that. So there was also this situation that the industry was pushing in favor of SSRI, and also women were more receptive to that because they were afraid of HT. So it's probably a combination of both that occur, and that we've seen this manipulation. Also for the increased fracture rates since 2002, we've seen the osteoporosis-related fracture trend from 2000 and 2005. On the right here, you can see on the red curve, the increase in radius fractures starting from 2002 and 2005, and that can maybe responsible for the stopping of HT, because we know that the hormones are really a first-line therapy for osteoporosis, for the prevention of fracture, and these data just confirm. For the hip in blue, at the bottom line, there was no increase because it takes lots of more time, and those patients are older before you can get some data on hip fractures. Now, we're an international menopause meeting. So you all know probably that for the first year, the G7, the Congress G7, it's occurring today, Thursday. How the people, they call it now the G6+1 summit. I don't know why, but it's occurring today in Quebec at Manoir Richelieu. And we think that they will talk about the climatic change. So, but here as scientifics, we can see that we can help them to see that the scientific evidence for global warming is probably post-Y due to hot flushes and night sweats that occurred after all women stopped the HT. Now, since Y, there's an indecision against HT. the type, dose, and route of administration. You can see on the left that we're ambivalent about hormones or going for natural products. So which way we're going to go, there's still questions. Dr. Simon published in 2014 a nice article and entitled it, What If? What if researchers had focused only on women aged 50 to 59 years old? Researchers had focused on women who had reached menopause within the past 5 years. Lower doses of conjugated equine estrogens and MPA had been used, because MPA was used mostly in the States but not in Europe. Different estrogens and progestogens have been used. Different route of administration had been used. So these questions raise a lot of issues that in our mind, as scientific and people taking care of menopausal women, must be addressed. So after WHI, there was research. There was research, but there really lack of randomized controlled trial that occurred like the WHI trials, because they are difficult to go for. Lots of money is involved, and the money comes either from government or the industry, and following why the money was not there anymore. So, but there were some major trials going on around the world, like DOPS in the Scandinavia, the KEEPS, ELITE, E3N, ESTER, Million Women Study, etc. So these studies were not randomized controlled trial, most of them, but bring some little news and light on the issue. So let's go with the different topics for the going what we want to know about the hormones. So hormone therapy and cardiovascular disease. So after the WHI came out, there were reanalysis. Why this randomized controlled trial was different at all the observational studies that we had in the past. There was so much a difference. We were so surprised that these differences were not in agreement with what we knew. So Lacroix in 2011 was just reanalyzing the data, separating the women that were 60 years and less, and those with 70 to 79. And they showed that effectively the acute MI, there were minus 12 for 10,000 women MI for the younger population compared to the increase in older women, which makes sense. That was also the same statistical difference. So the adverse event, global index of chronic disease, was minus 18 per 10,000 women, compared with the figures plus 48 in the older group. So these data started to bring in front the timing hypothesis. So the data were supporting the timing hypothesis, and now we really believe that this is what happened. The data, when you differentiate between the age group, you make some difference. So Rousseau, who was the first author of the previous WHI in 2002, it just came out with these results that we can see in green here. When you regroup the non-opposed CEE and the CEE-MMPA in the true groups, when you look at the figures for the younger age group, 50 to 59, you see a statistical difference in the total CVD mortality according to age. So these are the reanalysis that had been done. So the North American Menopause Society and also the IMS guidelines, they came out with a statement that the age and time since menopause are supporting the timing hypothesis. The effects of HT on coronary heart disease may vary depending on a woman's age and time since menopause onset. Women who initiate HT age younger than 60 years and or within 10 years of menopause onset, they have a coronary heart disease significantly reduced by 22 to 48%. All-cause mortality significantly reduced by 30 to 39%. There is a concern of increased risk of coronary heart disease in women who initiate HT more than 10 or 20 years from menopausal onset. But that's not what we do in clinical practice. I never see patients that come to me at 65 or 70 asking for HT. I mean, it never happens in my practice and probably in most of your practice. So that's not the way we're going. So for the deep vein thrombosis, what we see that there were questions about the premise for favorable VTE safety profile of transdermal versus oral. We know that there's some data that comes out saying, oh, oral is not that bad, safety is good also, even for VTE. But, you know, we know that oral estrogens, they undergo first-pass metabolism in the liver, and that results in a marked hepatic response, including increase in C-reactive protein, increase in insulin-like growth factor, increase in clothing factors, increase in hormone-binding globulins, and regression in the free testosterone and cortisol due to competitive binding of sex-binding globulin. As compared with transdermal estrogen, you avoid the bypass by the gut and liver metabolism, so you have the higher parent drug concentration and lower estrogen metabolic concentration in the blood. So there's a minimal effects on testosterone, T3, T4, and cortisol. So these metabolic changes may induce different response for clinical outcomes. So some of people, like later on, will see different studies analyzing some data. But there was a study published by Mohammed in 2015. And this study was a systematic review and meta-analysis of all these studies treating the VTE events, the oral HT versus the transdermal. So they regrouped 15 observational studies that had really the criteria to be included in this review, 10 cases control studies, and 5 cohort studies. Unfortunately, many people say, oh, we don't have randomized controlled trials to support that. But sometimes you don't need randomized controlled trials to support if a lot of people are going into something. I mean, I don't need a randomized controlled trial, because if I hit you on the knee with a hammer, I don't need a randomized controlled trial to probably know that you will suffer some pain, most of you. So the population involved was 22,000 over women with oral and 5,000 women with transdermal. And the follow-up period was ranging between 3 to 25 years. So the clinical endpoint was the first idiopathic episode of VTE, DVT, PE, stroke, or MI. Now, with this classification, 9 studies showed that there was a reduction in DVT with the transdermal as compared with the oral. And these are the statistically significant results. One study on PE didn't show statistical significance. The one study on stroke shows an increase in risk of stroke with oral compared to transdermal. And the risk of coronary event, there was 4 studies, but no data that were statistically significant showing a difference between the oral or transdermal. So this meta-analysis is still a meta-analysis, but the strength of the study, there was rigorous methodological approach, predefined protocol, comprehensive literature search, multiple databases, no language restriction. So the main limitation in nature was observational nature of included studies. That may include the risk of bias, reduce the trustworthiness of the results. But as I previously said, sometimes when you have lots of people going in one direction, maybe sometimes that's something that is probably real. So in conclusion, with from Mohammed, observational evidence suggests that oral estrogen therapy versus transdermal estrogen therapy may be associated with increased risk of VTE and DVT. There possible increased risk of stroke, and there's no increased risk of myocardial infarction. There's probably a safety advantage with use of transdermal as compared to oral, particularly in women at risk for thrombosis. But sometimes you may think that if it's better for women at high risk, it may be also very good for women at low risk, even if the safety issue is not proven for oral. I mean, at least you may be sure that you're not doing a bad thing with transdermal, even with low risk. So the dose of estrogen and the choice of progestogen may also influence the risk. But you can imagine that doing a clinical randomized trial trying to regroup all the formulation, all the products, and all the routes on the market, that's really impossible. So just to tease you before you're going to lunch, the HT and type 2 diabetes. So we have some data going on. The KEEP study, it was a randomized controlled trial with 27 women aged 42 to 59 years, and they were early menopausal status, which we want really to address. And the follow-up was for 4 years. 64% of subjects completed the study. And the study arms were armed with transdermal estrogen. It was Climara, 50 micrograms, and the Premarin, 0.45, and the placebo. And Prometrium, as the progestin, was added just 200 milligrams, 12 days per month. So when we see the biomarkers, and again, it's a surrogate marker. These are not the clinical events, but you've seen that the CEE compared to the transdermal, there's a change in the biomarkers, increase in HDL, lowering of LDL with the CEE, the increase in triglycerides, and the increase in CRP, the neutral on IL-6, increase in SHBG, and there was neutral on glycemia and insulin resistance, while almost all neutral with the transdermal. So for the menopause and the prevention with HT and diabetes type 2, again, there are many results of studies going on the literature, but when there was a nice article, a review article by Mauvais and Jarvis, and that's published in 2017, and it's really a regroupment of all the studies that are being done on this subject, and it's really the point of the endocrinologist, not the cardiologist, not the gynecologist, but the endocrinologist on the HT issues and the diabetes type 2. And their conclusion is that randomized controlled trials suggest that MHT with estrogens may be effective in reducing the risk of type 2 diabetes in postmenopausal women. So sometimes we think that HT can be a risk for women with diabetes, but on the contrary, it can be a help for their health. So, however, the FDA has not approved the menopausal hormone therapy for the prevention of type 2 diabetes, probably because there's a complex balance of risks and benefits in the studies that have been done. Also, probably that diabetes prevention is not a primary outcome of RCTs directly. So that's one issue that the FDA is probably asking before they would accept this approval for this disease. So their conclusion is for young women that have a hysterectomy being done and they don't have any diabetes, they're young, 50 to 59 years old, and less than 10 years after menopausal onset, the estrogen alone may be beneficial for prevention of coronary disease, a reduction in the incidence of type 2 diabetes. And that's either oral or transdermal. The young women with a uterus without diabetes, there's a neutral or beneficial coronary effects, but there is a reduced incidence of type 2 diabetes, reduced incidence. But when we use the ASCVD risk categorization, if the risk is low, the oral or transdermal route is probably the same. But when the risk is moderate, 5% to 10%, according to this ASCVD classification, then transdermal route is probably a more better approach for these patients, or also in obese women. For the young women with actually the type 2 diabetes, the oral route can be good for normal weight women if the 10 years again, ASCVD risk is low, less than 5%, because there's a beneficial effect on HDL and LDL. We've shown that there's an increase in HDL, lowering of the LDL, but however, there's an increase in triglyceride, which is not really good. And there's a stronger improvement in insulin sensitivity. In comparison, the transdermal route, the obese women, again, are those with a moderate risk, ASCVD, which is 5 to 10%. Probably the transdermal route is better. There's more beneficial effects on the inflammatory markers and triglycerides, and it may not increase the risk of VTE, as we've seen previously. The older women, 60 years of age or more, or then 10 years past menopause, it's again a question of clinical judgment. There's no randomized trial. It's your patient and you front to front and explaining and balancing the risk, and you have to consider all the other risk factors and make a decision according to both your impression and the acceptance of the women. Now, the breast cancer, MHT, that's a very sensitive issue. As clinicians, we're faced with that every time that women comes to us, the breast and hormones. It's like hormones equals the breast cancer. You just probably went out of the presentation by Bob Reed, who's giving exactly what we think as in the Menopause Society. The breast cancer is an important issue, but that's not all about hormones. So the risk of breast cancer in women associated with HT is really a complex issue. We've seen different study, million women study, WHI, and we know there's increased risk of breast cancer is primarily associated with the addition of synthetic progestogens to estrogen therapy. Probably, and also the duration of year. We've seen that. The question one of the participant was asking after 5 years, but when we speak to patients, we just say, you know, after 5 years, yes, you have a lowering of colon cancer. Oh yeah? Lowering, the risk of colon cancer is reduced. You take all women, they use HT for more than 5 years, their colon cancer is reduced. Oh, that's good, there's colon cancer in my family. So I tell them, you know, but it's just a 6 per 10,000 women lowering of colon cancer. Oh, that's just it, so it doesn't worth talking about it. So, okay, fine. For the breast cancer, it's 8 per 10,000. Oh. Why didn't nobody told us about it? Because that could change in some patients their decision. So that's what we have to tell the patient. It's always their decision, not my decision. But my duty is to give them the right information to make the right decision according to her perception. The risk may be lower with micronized progesterone. In Quebec, at least, we're covered with the health plan, so we can prescribe the progesterone, micronized progesterone over MPA, so we prefer that. And in Europe, it's mostly the micronized progesterone or the progesterone, but in the States, in the past, it was MPA, so that may be different. The risk of breast cancer attributable to MHT is small, as we've seen, and the risk decreases progressively after treatment is stopped. So also to put in favor, just to reemphasize the risk factors for breast cancer, there was a study by Singletary in 2003 and showing that there are different risks associated with breast cancer. And if you see that the alcohol intake is 1.2, it's almost similar to the use of HT as a risk factor. And mostly what is the most important risk is something you cannot change, is the germline mutation. If you see the increased risk there compared with the normal women. We all know that family history also is something you cannot change but increases the risk. And the risks do not add each to other, but they're just independent risks and they are there. So I think people get more information with this little table. So coming from NAMS guidelines, the effect of hormone therapy on breast cancer is complex and conflicting. We've said it. The effect of HT on breast cancer risk may depend on the type of HT, dose, duration of use, regimen, route of administration, prior exposure to HT, individual characteristics. But altogether, probably the HT is a low risk, but it has to be explained, and the decision again lies on the patient. Now the smoking and HT route, I like that picture. Why avoid oral estrogen in smokers? Smoking has a dose-dependent anti-estrogenic effect. That means loss of efficacy. The hepatic clearance of estrogen is increased in smokers, and it's avoided with transdermal estrogens. So the smokers have more vasomotor symptom and more vulvovaginal atrophy than other person, and they have also earlier osteoporosis, tooth loss, and less endometrial cancer beside that. So, I mean, for the smokers, sometimes you may start with the oral route if they ask for hormones, but sometimes they will say, oh, my symptoms are not relieved. So instead of increasing the doses, you may just switch to transdermal or initiate transdermal just at the first step in those patients. Now, the HT and sexual function over time. The effects of oral versus transdermals were shown in KEEP study. There was not a specific study on the sex, but these are like little sideline objectives of the study. So if systemic HT is needed and women have low desire, the transdermal estrogen therapy may be preferred to oral. There's some indication that it could help compared to the oral route. So the transdermal improves the arousal and desire, and a neutral effect on SHBG. So neutral effect means that you don't have the increase in SHBG. So the SHBG, if it increases, it captures the free testosterone, and testosterone may be something to deal with the desire and arousal. The oral route, there's a reduce of bioavailability of testosterone. So that could be an explanation. But there are not very strong powered studies on that, but it's like a tendency. Now the gallbladder and liver. Hope you don't have these stones in your gallbladder after my dessert, very hyperglycemic dessert. Now, the NAMS have shown that after analyzing all the data, the risk of gallstones, cholecystitis, and cholecystectomy is increased with oral estrogen alone and combination HT. There's a lower risk with transdermal HT than with oral and with oral estradiol compared with CEE. And there's no randomized controlled trial, again, just to prove this issue, but knowing that we avoid the first pass liver effect, it makes sense. There's an association of HT with slower fibrosis progression in Hep C and with fatty liver that is observed, but there's no randomized controlled trials, again, to establish the benefits and risk of HT in the postmenopausal with women with active liver disease. So that's me a few years ago. So don't ask me to repeat in front. That's a private picture. So as far as hormone therapy in bone and joints, the hormone therapy effectively prevents postmenopausal osteoporosis and fractures. It has been well documented in many studies, so now it's a given. We know that it's accepted as a first-line therapy for the prevention and even the treatment of osteoporosis. Women in the estrogen alone and estrogen progesterone therapy overall cohorts in the WHI had significant 33% reduction in hip fractures, which is really something significant. After treatment discontinuation in the Y, beneficial effects on bone dissipated rapidly, but no rebounds was seen. And women in the WHI showed also less joint pain or stiffness. We see very frequently in our practice women starting around 48, 49, 50, early menopausal, and they complain of pain and aches in the larger joints. And they say, well, how come I have that? I don't have arthrosis or whatever. And so they really complain about that. And when we talk about the difference of status of hormone in their body compared with the previous, they understand that, oh, that may be some kind of a symptoms associated with this transition. Now, we know that women of menopausal age, the women we see every day, they are busier and more engaged than ever. They're working hard, they're working outside, they need to be in good health to provide the good work and different responsibilities. Bus drivers, postal delivery, civil servants, physicians, architects, lawyers, anything. And like Maureen McTeer was saying yesterday evening, she was with Elaine, and they went to coffee here in the Fairmount, and the first two persons they met as the servers, they said, oh, you're here for the menopausal thing. I have really hot flushes, and nobody takes care of me in Vancouver. So we suggest to move to Quebec or Ontario, but they prefer the high prices of housing here in the Vancouver area. So it is high time for healthcare professionals to take up our responsibilities to adequately care for women in the perimenopausal and menopausal stages. We are approaching now the light at the end of the tunnel. Women are suffering without our help, and we need to help them. So in summary, we favor transdermal estrogen therapy for diabetic women, obese women, women with hypertriglyceridemia, VTE risks, moderate 10 years risk of ASCVD, smokers, women with sexual dysfunction, gallbladder stones, women's preference, and that's very important. And the adequate insurance. We live in Quebec, I live in Quebec, and we have a health plan, it's public health care, and everyone in Quebec must be insured for the pharmacy. There's a government plan, some have private plans. So when you order prescribe HT for women, you have to take into account, are you the public insurance or the private insurance? Because it makes a difference. When they go to the pharmacy, the transdermal are not accepted without a exception prescription. So they go to the pharmacist, and even if you order the transdermal, they come back and ask you, I need something else. It's not on the formulary. So we have to deal with that. That's one consideration, even if we think that for some patient, the transdermal would be the best. Now, in conclusion, there's evidence on the potential impact of the route of administration on the risk of clinically important outcomes, but it remains limited because of lack of a randomized controlled trial. There are small differences that appear to exist between oral and transdermal estrogens, which may have implications for clinical practice, but neither results nor study designs are uniform, so we have to deal with that. A large randomized clinical trial utilizing different doses, different oral or transdermal preparations combined with different progestogens could provide more robust findings with significant clinical implications. But we all know that this will probably never be completed. So hormones should now resume their flight and regain the place they deserve, and that's what we have to do. Thank you. So we'll...
Thank you very much, Dr. Fortier. We're going to continue with Dr. Jolly, who's going to go through some cases for us, and then we'll invite you for questions.
So good morning, ladies and gentlemen, and welcome to our symposium. And I want to congratulate Michel, because I came up with this symposium and I said, now who could go through all of this information with all of the experience that he's had? And I think that you all agree that he did an excellent job. I would like to give you some illustrating cases. And definitely there is some bias here, because I had to work out cases that would fit into the transdermal milieu. So here are my disclosure statements. And I must say that I've been a little biased, because I had to figure out which cases would illustrate the information and all of the good clinical judgment that has gone into your first presentation. So This is case number 1. Now, please take a pen because I'm going to present 5 cases, and you may not agree with what I've said, but at least during the discussion phase, which is the interactive portion, we can have some good opinions. So case study number 1, this 48-year-old nulla gravida airline attendant is suffering from severe and disruptive vasomotor symptoms. She had her last menstrual period 14 months ago and has had significant problems with sleep disturbance, which were greatly impacting her ability to perform her work. And she does many trans-Pacific flights. Okay, how do I go back? So she is slim, fit, and active. She has a normal blood pressure. Physical and pelvic examinations were perfectly normal. Her labs were normal, and I think it's a good idea when you're doing evaluations to look at the TSH. 1 in 4 women will have thyroid dysfunction, which can cause, as you well know, problems with vasomotor symptoms. It's nice to have a glucose level and a lipid profile because we are looking at this from the initiation. This young woman needs some hormones. And in her case, we did do an FSH, and it was significantly elevated, although you certainly don't need that, as you well know, to make a diagnosis of menopause. But she is on the younger side of the menopausal timing, so age 45 to 55. Mammogram is essential, and in her case, it showed moderate breast density. And she is trying to stop smoking. But she did listen to your little rant with regards to that. Her family history is unremarkable. So, what is the situation for this woman? Well, definitely menopause hormonal therapy is best for her constellation of symptoms, which is quality of life. Beware the pitfalls of prescribing and the regimens. So in the late transition and in early menopause, you may have recrudescence of ovarian function with some ovulations. But we can't really give this woman cyclic therapy, although it crosses our mind. And maybe we need to give her a little less or lower dose estrogen with a higher dose progestin to take care of that bit of estrogen that can come. And those of you who have done a lot of hormonal therapy, and you are here because that's what's happened, will find that along with the estrogen that you are giving that's low dose, every now and then it can fit into a higher dose. So definitely continuous combined therapy is appealing for her. And I skipped over, she also had some vaginal dryness, and on her long flights there was some chafing. So we said maybe it's a good idea to use some barrier cream. And we talked about her lifestyle changes and again stressed the non-smoking. Now that's pretty easy, number one. So transdermal estrogen would appear to be the best for her. And adding progesterone, you might think about a continuous combined patch, and we do have that available. Not used terribly much in Canada, but definitely would be very convenient for her to give her a continuous steady state. So that's number one, pretty easy. Case study number two. A 36-year-old teacher has premature ovarian insufficiency with complaints of severe vasomotor symptoms. I don't know what to do to get this out, but you don't need to see her face anyway. She recently, her severe vasomotor symptoms are definitely interfering with her sleep and with her work. That is my phone. Those are my children. Please excuse me, I am a mother as well. I don't know.
Click on the menu.
And I don't know why it came. I didn't even press anything. Where's our fellow? I don't know. I love computers. I wonder if somebody can...
He's coming.
If you can get rid of this for us, and while you're doing that, I'll just carry on. So this 36-year-old teacher has premature ovarian insufficiency, and she has complaints of severe vasomotor symptoms. She's had the normal workup, and actually her diagnosis is idiopathic POI, And we've ruled out, thank you very much, we've ruled out any issues related to that. And infertility is not an issue because she recently underwent, she's surgical menopause. And she underwent a total hysterectomy with bilateral oophorectomy. So premature surgical menopause, not idiopathic POI. However, had she been in that case, she would be thinking about definitely hormonal therapy. So the reason for her surgical menopause was chronic pelvic pain and chronic PID, and she even had tubovarian abscess. So after 6 months, and she was treated by another physician, she comes to you. She's been on oral estrogen. She has continued, even with her oral estrogen, to have vasomotor symptoms, fatigue, decreased energy, and decreased libido. So, did I? So, what is the situation with this lady? 36 years old. Why? Even with hormone therapy, and of course you would want to know what the dose was, and the dose was conjugated at 0.625 milligrams, the common dose. That is given to postmenopausal women during the normal time, and she was taking it orally. Not enough estrogen, you think? Absolutely. Is she having poor absorption from the estrogen? But even if it was poor absorption, 0.625 of conjugated equine estrogen in a 36-year-old woman, not very much. So we would definitely take the high road in this case, switch to transdermal estrogen, definitely increase her estrogen dose, and at this point in time, you're not wanting to give a 0.625 equivalent 50 microgram patch dose. This is something that needs the double dose, and you need transdermal, and you can move up slowly to an equivalent 3 pumps a day of 17-beta estradiol gel, or you could move up to 75 patch or 100 patch, but definitely she needs more estrogen. So if you weren't sure, and in this case I don't think we need to measure E2 levels, but you know, with transdermal estrogen you can get significantly good results. With conjugated equine estrogen, there are so many estrogens there, certainly more than 20, and it's mainly estrone, and then the equine estrogen, that you really can't get an accurate account, and that's not what I would recommend here, but some people might do that. So you may, for her decreased libido, need to add an androgen, but this you would want to do in a sequential, this you would want to do in a sequential phase, and you would want to get her estrogen levels up and her main quality of life symptoms better under control. And you talk about stress, and it's stressful flying in the air, trans-Pacific, and it's stressful just doing your ordinary job. Appropriate lab work, you may have discussions about this, but I think you need to at least do her CBC, her thyroid, and make sure that you know what her lipid profile is. And what's important, once you get that dosage and add androgen, and young women who have premature menopause or premature ovarian, in this case it's not insufficiency, she really needed hormone replacement therapy, young women should be treated until the average age of the menopause, which is age 51. But remember, in this case, they're going to be taking estrogen alone. So although we can't really say that CEE 0.625 is the same as 17-beta E2, you can continue her after age 50, 51 for another 5 years, and of course with our new guidelines, even longer. So she will be set on estrogen. So case study number 3, a 49-year-old nulla gravida whose last menstrual period was 3 months ago. Her mother is a breast cancer survivor. She had a history of the DVT from about 20 years ago. She presents reporting difficulty sleeping because of her vasomotor symptoms. She feels that this is interfering with her ability to function, and she also reports that she is tired all the time with no energy. We're going to make her a smoker, and she actually was one of my patients and was smoking when I first saw her, about a half pack a day, and had been smoking for a long time. Remember, she is a nulla gravida, and when you did her mammogram, she had dense breasts. And we don't in Canada always have good reporting. I find that in Europe, you know whether it's fatty infiltrated, mild increased breast density, moderate, or greater than 75%. But very important to know that breast density is an increased risk factor for breast cancer. And in Singletary's evaluation and a study in 2006 that Michel prevented, they didn't take breast density into consideration. But you can certainly say to women who have excessive breast density that this is a major cause of an increased risk. So, what do you think about this? Well, in my mind, if I should make this flashing danger, 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 49-year-old smoker, DVT 20 years ago, mother breast cancer, was it premenopausal, postmenopausal? How dense were her breasts? Well, her DVT in the past was postpartum. So that's a little bit reassuring because she was in a hypercoagulable state. And she is slim, fit, and active, although she is a smoker. How dense were her breasts? Well, in her case, she had moderate breast density, and her mother had premenopausal breast cancer. And is she afraid of breast cancer? Well, of course, they're all afraid of breast cancer. So although her early menopause at age 47 has severe vasomotor symptoms, I am very reluctant to prescribe hormonal therapy for this patient. So take out your pens. What about you? Would you prescribe hormone therapy for this patient? Would you give her an ultra-low dose? Would you think about giving her micronized progesterone or dydrogesterone? And is the dosage important? And how carefully would you follow her breasts? Obviously, she's having annual mammograms. This is a case that presents a conundrum. So case study number 4, a 52-year-old, 2-year postmenopausal woman experiencing, and they're all going to have vasomotor symptoms in this set, sleep deprivation because she's exhausted, she has decreased libido, and poor sexual response, but not gone, and she has dyspareunia. But she has been estrogen deficient now for 2 years. She's experimented with often the usual, black cohosh and some of the others, but has had no success. She has, with her family doctor, who's very against hormone therapy in any situation because he's back in the WHI era, has told her that hormones are very bad and very dangerous. And with a family history of breast cancer, it is absolutely contraindicated. So trials of clonidine and venlafaxine also have resulted in not a good response. And she's tried different SSRIs and tried some that over the 2 years, tried at least 2. And she had a maximum dose of clonidine, which is 0.5, 3 times a day, but still, and it gives you maybe a 40, 50% reduction in those patients that respond. But in her case, this was to no avail. So she's interested in trying hormonal therapy, but she doesn't want to have any bleeding. She currently smokes a half pack per day, and also, to make things interesting, had a history of perimenopausal abnormal uterine bleeding, where there was no gynecological issue. She had, by someone else, an endometrial biopsy, and there was no problem, no treatment for that, because the only treatment she was offered was a birth control pill, but then the gynecologist said, oh, no, you can't take the pill because you're a smoker. So what do you do for this woman who is a smoker, who is concerned about her decreased libido, and who has vaginal estrogenal deficiency? So a continuous combined hormone regimen is a good idea. Because of her smoking, and because of what Michel said, transdermal estrogen would appear to be a good choice. If you want the least effect on the breast, micronized progesterone is a good idea, and cyclic therapy may be better than continuous combined, but you'll have to explore that. Because of her history of abnormal uterine bleeding, probably a good idea to do a baseline ultrasound. She definitely will need vaginal estrogen and lubricants, and she may need added androgen. So you do your best with quality of life counseling, diet and exercise, and in her case, cessation of smoking, and that is your first consult. So to just go over what Michel said, why avoid oral estrogen in smoking? Well, you hope you're going to have her decide to stop smoking, and it doesn't happen overnight. And although it's not a contraindication to hormonal therapy, which some people feel it is, there is a dose-dependent anti-estrogenic effect, so that when you give oral estrogen, there is a loss of efficacy. And you can point out to your patient, just as Michel said, that you can have, due to long-term smoking, decrease in elasticity in the skin, and you can have increased wrinkles. There's a problem with hepatic clearance of estrogen, as you know. And truly smokers have more vasomotor symptoms, and that has been shown in some smaller studies. And so you can point out to her that if she does stop smoking, it's not going to be bad for her hot flushes. And definitely smoking causes bone loss as well, tooth loss, but less endometrial cancer. So here's our final case, case number 5. So this is a little bit more complex. And again, remember, they're skewed all towards transdermal. So this is a 52-year-old housewife. She's G1, P1, had her period, last menstrual period, 12 months ago. She is also symptomatic with hot flushes, 10 per day, with sleep disruption, irritability, and then fatigue. Now, she's had a history of anovulatory infertility, and she went to the fertility clinic, has always had problems with her weight, and at one point, somebody did tell her that she had polycystic ovarian syndrome. She has been a non-insulin dependent diabetic patient just recently, since the age of 50. There is a family history that is significant of cardiovascular disease and of diabetes. Both in her mother and her brother had a heart attack very early at age 40. So this is obviously a very significant cardiovascular history. She takes metformin, 1,500 milligrams a day, and a little bit of hydrochlorothiazide, 25 milligrams a day. So these are her lab results. So she is obese with a BMI of 34. She has diabetes, but hypertension as well. And the hydrochlorothiazide is not really helping her as much as it should. So she needs better control of this with regards to cardiovascular outcomes in diabetic patients in the future. Her hemoglobin A1C is, I don't think I put that on here, but it's just borderline about 7. And when you did her blood work, her fasting glucose was 7, and you can see it's elevated, 3.6 to 6.0, not too bad. Her FSH is 90, and if you look at her lipids, they're all out of whack. Her total cholesterol is increased to 7.2. You can see the normal numbers on the side. Her HDL is low, which you would expect in this type of patient. You like to see it at least over 1. Her LDL is elevated, and her triglycerides are elevated. And you can see triglycerides much more elevated than this in diabetic patients. So what are the issues for management in this patient? So looking at postmenopausal diabetic patients, well, some of the internists will say, with their increased risk of cardiovascular disease, don't even think of hormones. This is the wrong thing. But you've got a crack at it, and should we give her hormones? Well, let's look. Definitely we'll go over, again, lifestyle management. We'll talk about quality of life management, improving her glycemic control, getting her hypertension under better control. And sometimes our family physician colleagues are not terribly aggressive with regards to control, which they usually are when you have a diabetic patient. She needs to have management of her dyslipidemia to bring it into line, and she needs aggressive management of her dyslipidemia. And I think she needs menopause hormonal therapy because with what Michel told you, this control of the glucose is assisted by hormonal therapy and the right hormonal therapy. So is transdermal estrogen safer than oral hormonal therapy? And I got this slide from another set of lectures, and people were able to vote. So yes, no, maybe, I don't know. So what in this audience, if you would say yes, show your hands. And of course that's going to be the case because this is the diabetic patient. But definitely you would be surprised sometimes at the answer. So I think I missed one. Okay, so this is where it goes. So, yeah, I wasn't even near it, but it's very sensitive. Michel has much better control. So what about transdermal hormones? Well, we talked about the renin-angiotensin-aldosterone system, so we are bypassing the liver on the first pass. It definitely goes through estrogen on the second pass, but oral estrogen raises renin substrate, but there's no reported effect with transdermal estradiol. So the increased renin substrate with this patient, if she's given oral hormones, may contribute to the hypertension. May not, but may. So why give something that might occur? So transdermal estradiol plus progesterone, and in this case, it was, in this particular study, it was not micronized progesterone, but in micronized progesterone, you would even expect better. In this one study, actually, it substantially lowered blood pressure over 8 weeks. But the best that you would hope for is that the blood pressure would remain neutral, so that with transdermal, there is no increase. The beneficial effects of transdermal estrogen on the cardiovascular system, and this you've heard, so the beneficial lipid effect decreases LDL, increases HDL2. With HDL, you get a better increase with oral estrogen, but with HDL2, transdermal can be seen. Definitely, triglycerides are lower. With oral estrogen, your triglycerides can be increased up to 35%, and with transdermal, it is neutral. There is, as Michel said, a beneficial glucose-insulin effect. No adverse hemostatic effects because you are bypassing the liver and you are not stimulating the clotting factors. And there actually is a beneficial direct vascular effect throughout the body, but especially with regards to cardiovascular disease in the heart with with transdermal estrogen. And when you have looked at the studies, when 17-beta-E2 is transfused in patients who are menopausal, who have angina, there is a decrease. So that's a good thing. And of course, no increase in C-reactive protein. With oral estrogen, C-reactive protein can be increased up to 85%. Now, this is an inflammatory protein, and although there are different types of C-reactive protein, high sensitive, the C-reactive protein as an inflammatory situation is not something that you want really in any patient, but definitely not in the diabetic patient. So I don't quite know where to put my hands so that I don't trigger this. Michel, tell me. So here's the lipids summary. So if you look at oral versus transdermal, and I've put the increases in red and the decreases in green. You can see what the situation is with triglycerides. So 15 to 35% increase with oral, but 6 to 18% decrease. And if you look at LDL cholesterol with oral estrogen, there is a decrease, not quite as much as with transdermal, but that's neutral. With HDL cholesterol, 7 to 15% increase, minimal change with transdermal, and that's okay. With Lp(a), pretty much the same, pretty much decreased, and there's the C-reactive protein, 85% increase, and neutral with transdermal. So estrogens differ, and their effects by route, and the best evidence of this difference is regarding VTE and stroke risk. And in the United Kingdom, a general practitioner's research base, so I did this. And oh my gosh. There we are. So thank you for being patient, which has been in existence for quite a while. In the 7-year study, showed no increased risk of stroke among transdermal estradiol users, the relative risk being 0.95, but definitely an increased risk with oral estrogen, and that's the relative risk of 1.28. In the Esther case control study, which is an observational database on truly a small number of patients, oral users had a 3.5 increased risk of VTE compared to the transdermal users. And so I did have the slide there. Okay, this is the E3N cohort. And, all right, so I don't know what happened to the slide, but it showed exactly that in graphic form. If you look at the risk of VTE in the E3N study from France, which had 80,000 women in the cohort, and if you look at the never users compared to past users, it's pretty much in the neutral area. If you look at current users of oral estrogen, and I've highlighted that in the red, there is definitely a threefold increase, and the current users of transdermal is pretty close to zero. So no increased risk. So what about dose? In this same study, in this cohort of women using estrogen patches compared to non-users, the risk of stroke was not increased with the transdermal users, and they were using pretty low dose, even less than the 50 microgram patch, but the risk was increased with doses over the 50 transdermal patch. So 75 and 100 increased the risk. And if you look here, you can see that in the red highlighted area, which shows an increased risk, it was with greater than a 50 microgram patch, with the oral route, low dose oral, still a little bit increased, but better. High dose, a little bit more. Now, this is an observational study, but when you look at the data, even though you can read about it, it is quite impressive. So what about age? Well, I won't go through the KEEP study, but it presented the 48-month data showing excellent cardiovascular safety in women within 36 months of the menopause, both oral and transdermal. And the ELITE trial, so we do have 2 randomized controlled trials in the United States, and the ELITE trial, which looked at transdermal, reported a 50% reduced cardiovascular risk in younger patients. And when you looked at, in this study, patients greater than 6 years past their final menstrual period, there was an increased risk, and there was of a surrogate marker, coronary calcifications. So transdermal estrogen does not increase SHBG, as Michel said. The KEEP study also found, as he said, an improved desire with orgasm quality in the transdermal group. So when you look at the decreased libido, at least you can try estrogen initially. No difference in breast cancer rates in the E3N shown by Roots, but there may be a small increase in breast density only compared to a larger increased risk of breast density with oral estrogen. And I can harken back to the PEPI trial. And the PEPI was done way back in 1996, a randomized controlled trial using oral estrogen, 0.625 of CEE, and micronized progesterone 200, 1 to 12, which showed the least amount of breast density. The continuous combined showed the greatest amount, and Provera cyclically did show sort of in between. And of course, the best was unopposed estrogen. I want to give you this information about the steroid effects on the breast, looking at baseline compared to 2 months of oral CEE and MPA, and looking at the increase in hyperplasia in the breast tissue. And when you compare that to the bottom panel after 2 months of transdermal E2, and this was oral micronized progesterone, there is truly a very significant change, and you can see the colored black areas. So the effect on the breast with transdermal and micronized progesterone may be something to consider in women who have fear and an increased risk of breast cancer. There is a steady state that we really produce, as you all know in this room, and that steady state of estradiol has a good effect on patients that have migraine headaches, and cyclical therapy and oral therapy, which is absorbed oral estrogen kind of in a cyclic fashion every 6 to 8 hours, with PMS, depression, and with difficult vasomotor symptoms. So think about transdermal there. And here is the steady state data. Now this is, I have not seen this in clinical trials, but this is from old data from the company in 2002, looking at the estrogen patch with 0.375 patch twice a week and 0.75, looking at estrogen levels. But look at that steady state, which you can get twice a week. Sometimes you have to give it every 3 days, the patch, because it starts to wear off. But bear in mind that for transdermal situations, this is a very good thing. If GI issues, as Michel discussed, and I won't go over, nausea, reflux disease, GERD, malabsorption, intolerance to oral estrogens, gallbladder disease. So in conclusion, before we get to discuss, the symptomatic postmenopausal diabetic patient will not impact diabetes mellitus if you give them transdermal therapy, may even improve the patient's profile, the transdermal estrogen, will definitely improve her quality of life, will not increase triglycerides, will not increase C-reactive protein, may not increase VTE risk if you use lower doses, may not increase stroke risk, especially at lower doses, will not increase blood pressure, has a minimal effect on coagulation factors, and certainly could be a first-line therapy in many cases, even if you're not concerned in all of these areas, and patient choice is important as well. And when should you consider using transdermal estrogen? This is the summary, and it's pretty much the summary that Michel had. So for quality of life, for patients with underlying medical conditions, the DVT, diabetes, gallbladder hypertension, for steady state drug issues or drug release with transdermal estrogen, be it the gel or be it the patch. So it can really affect the daily mood swings, depression, anxiety, migraine, if people give you a history of menstrual migraine, and it's pretty good for patients who do shift work. And this was our stewardess. The inability even to use oral tablets with the GI issues and problems taking a daily pill, obviously in smokers, although you can use low-dose oral estrogen as well, and very importantly, patient choice. So I did get to the final slide. Thank you very much. So I hope you have some questions.
So we invite people to the microphone if you had questions for our doctors, and I want to thank them both for outstanding presentations, very thorough and detailed. Thank you so much again. While we're waiting, I had a question. When we talk about transdermals, I often have patients that say, well, if I'm going to use a transdermal, why don't I just use a bioidentical? And I wonder if you could comment on how you counsel patients around that question.
Can you repeat, please? I think
so when we're offering patients transdermal hormone therapy, often they'll say, well, then why don't I just use a bioidentical? So I wondered about counseling patients in that case.
It's because
So the question is, well, how do we counsel patients who say, what about bioidentical, be it either transdermal or be it oral? So the very first thing we tell her is that we do have bioidentical hormonal therapy, and that's transdermal estrogen and natural progesterone. Can you hear me? So bioidentical does exist. Number one, if you're talking about bioidentical that's compounded, then the compounding makes a difference. So most of us, not all of us, in menopausal medicine like to have evidence. We practice evidence-based medicine. We tell our patients that. We need to look at clinical trials. We need to look at good outcomes, efficacy, and of course we want to look at safety. So the bioidentical compounded hormones that you brought up quite well don't have any evidence. There is not any safety requirements by FDA in the United States or the Health Protection Branch in Canada. So that worries us a little bit. And as these are compounded in various pharmacies, and they're all over the world, there are no safety issues. We don't have quality control. So I don't like, personally, and many of my colleagues, so I don't take the whole blame, really prefer to use something that's tried and true and safe. And that's what I would recommend for you. And I don't really think that at this stage we have the data, nor do I ever feel we'll get the data for bioidentical compounded hormones.
Can I add something?
Please.
In Quebec, we don't have that many patients that are requiring the bioidentical compounded products. Most of the patients, when they come, they know the word bioidentical, and most of the time they refer to this 17-beta estradiol and natural progesterone. So when we're talking about hormones, our first thing is, I'd like bioidentical. They just want, so we just explain what is the natural estrogen and the natural progesterone and whatever they want. We have that, so it's easy. But we don't have, in our clinic, we don't have that many patients that are requiring those compounded. There's in different areas of the world, it's differing, but not in our practice.
Thank you. Dr. Black.
Thanks. So thank you for the presentation. I would just like to say something about the science. So Michelle, you said we don't need a randomized controlled trial to say when you hit your knee it hurts. And I agree to an extent, but I'd just like to ask the audience to have a little bit of caution with how you interpret some of these studies. The observational studies about VTE risk often did not control for the dose of estrogen, the concomitant endometrial protection agent, as well as the age of the patients in the study. In the Esther study, the original Esther study had 32 patients with an average age of 62. Is that extrapolatable to the patients that we're seeing? The stroke study, and it said on the slide there that low-dose oral was considered up to 2 milligrams of 17-beta estradiol. And we know that that's about equivalent to a 100 microgram patch. But the transdermal comparator was a 50 microgram patch. So it didn't control as well for the dose of estrogen that was going on. And about the cardiovascular risk, to try to draw a straight line between CRP level and cardiovascular risk is probably not the whole story, because all of the studies demonstrating cardiovascular benefits have been done with oral estrogens. There aren't any studies on transdermal estrogens which demonstrate cardiovascular benefit in terms of patient outcomes like MI. So I think that this is an evolving area in science, and I think it's important to take a critical look at the literature with a slightly jaundiced eye. A meta-analysis is only as good as the studies that they've examined in the meta-analysis. And if all of the studies in the meta-analysis have the same biases or flaws, like not controlling for dose or endometrial protective agent or age, the data that you're going to get may not be as robust as we think. So sorry, it wasn't a question, it was a comment.
Thank you, Dr. Black.
So thank you for your comment, Denise. I agree with different things, and I disagree on different things. I would like to ask Denise if she can tell me if there's to her knowledge, a randomized controlled trial showing that smoking is associated with the pulmonary and the lung cancer.
Actually, there is. When they've looked at relative risk, smoking has a relative risk or association with lung cancer of 19 or 20. Not quite as good as high-risk HPV and cervical cancer, which is 400. But nonetheless,
But that's not a randomized control trial.
You're right, it might
That's
not
what
be
I mean.
randomized,
So
you're right.
that's what
relative
we
risk.
call observational studies.
Absolutely.
So I agree with you that low dose, all the studies, they're not randomized control studies, but when you gather different studies that all point in a certain direction, that may reflect something. We had for the coronary heart disease and the cardiovascular disease, we had some indications that taking hormones would prevent that. We had many studies. We were saying that it would prevent about 50% of cardiovascular disease in the future, and which WHI didn't show, to our surprise. But when we are coming back to reanalyzing the data and we address the issue using the population that we are using HT, then we come to a different set of results. So I mean, yes, for sure, we cannot say that transdermal is much safer than oral. That's not the point. It's just a choice for different patients. Patients that are at low risk, you take whatever you want. It doesn't matter. It's just the choice of the patient. But patients that are at higher risk, there may be a choice of preference going with transdermal, even if you don't have a randomized control study. And I'm not I'm not a person that's selling transdermal or HT. I'm just trying to help my menopausal patients, giving them the best information available.
So there really, as Michel says, no controlled clinical trials on smoking, but we have to rely on the basic physiology, and we know what happens in smokers. We know about the hepatic clearance. So right away you think about what is best for this patient. With regards to sex and sexual desire and libido, we know that oral estrogen increases the SHBG and then mops up the free testosterone. So depending upon what there is, many women do very well with oral estrogen. But if you have tried oral estrogen, or if you're on oral estrogen, and I don't know if many of you have observed this, that libido can go down when you go on oral estrogen from point A. So I think that we practice evidence-based medicine. We look at things, but I think we need to practice good clinical judgment as well, along with the evidence-based medicine, and sometimes we have to extrapolate. So I agree, it's not transdermal for everyone, but it is an excellent, excellent choice in some of those clinical situations, in fact, many of those clinical situations. So in the 5 cases, do you have any comments? Would anyone have done things differently? For example, with a stewardess who has need of a continuous steady state, who has the typical menopausal symptoms, and we don't have problems. We know she needs estrogen. We know she needs progesterone. Would she be okay with oral? Well, she wanted something other than oral because she found that a little bit difficult, but could you have given her oral? Would anybody have given her oral? So that's just a quick, simple, illustrative case. The case that we do need to talk about, however, is the case where the patient was loaded with regards to, and she was young, 47, 48, and she had very, very difficult menopausal symptoms. But she was single. She was nulla gravida. She had increased breast density. Her mother had premenopausal breast cancer, and she was a smoker. Would you have given her hormones? Would you have cautioned her? Would you have tried to get her to stop smoking? Of course we all would have done that. So I put that in because my first impression was, you know, you need some help, but these are the risks. So in fact, I did give her hormones, but I was inclined to say, uh-oh, I need to be very careful. So whatever I give you is going to be low dose, and in her case, it turned out to be a very low-dose transdermal patch with natural progesterone, which was cyclic, because there's a little bit of data, not much, that cyclic hormonal therapy has less of an impact on the breast. And I really like the French situation. They have a breast break. I do that all the time. So I can give continuous combined, and at the end of from getting 1 to 25, So I try, even though there's no data, I've been to my French colleagues and say, tell me about the data when you are using continuous combined in a cyclic fashion. And my answer is usually, we don't have any data, but we all do it. So any comment about that?
So if I might, I know we have a couple people very patient that have some questions, and we could certainly talk a long time about different trials and different kinds of data and have very robust discussion, but respectfully, yes, go ahead.
Thank you for addressing case 3. I was going to ask you what the approach would be. In the States, we get very poor coverage for transdermal by the insurance plans. So we're using depo-estrogen. Do you consider that a transdermal?
So I'm sorry, you were asking about depo-estrogen?
Yes, injectable estrogen as a transdermal. Is it?
In Canada, do we use injectable estrogen? I
No,
don't
we
think so.
don't use that, but yes, injectable estrogen is transdermal.
Correct. So we can somewhat extrapolate and apply all these benefits to something that's more affordable?
You don't get a steady state, as Wendy said. And I'm pretty sure your estrogen levels do go up, but I mean, it totally depends upon how much you inject.
Well,
So it sounds like the physiology, although it is technically transdermal versus an oral agent, that your physiology is not quite the same. You get peak levels that are very high, and you don't get the steady state that we see with the patch. And Dr. Wolfman will probably give us some more comment on that.
Well, my question's in a similar line of questioning. I wanted to ask about transvaginal versus transdermal. I see a lot of patients in family practice coming in with complaints of low libido and vaginal dryness. I know to treat with vaginal estrogen is good, but what about vaginal testosterone or transdermal testosterone? No one's commented on testosterone.
We don't have in Canada, or I don't think in the United States, any kind of testosterone available. So that would be a male derivative like androgel, and then you have to use 1/10 of the dose. And so there are really no guidelines about it. In Australia, definitely, they did have the transdermal androgen patch. We also in Canada don't have the estrogen ring, which definitely is transdermal, transvaginal, and we don't have, as they have in Europe, a nasal spray, which also is transdermal. So in different parts of the world, you need to look at the dosages, and these are all 17-beta estradiol, and then extrapolate from them, looking at the various studies. So I am sure that transvaginal estradiol is good, but I don't know the dosage, and I don't know what to be expecting.
I would just tell that at 2 p.m., 2:10 p.m. in the Vancouver, there will be a debate, testosterone for FSI-AD, yes or no, by Susan Davis from Australia, which is for, and Johannes Bitzer, which is against. So that could be interesting, a session to hear.
At 2 p.m.?
Yeah,
Yes.
14:10 in the Vancouver room.
Here.
Okay, excellent.
It's here.
Thank you.
And if
Should
I
be
just
an
might
interesting
add,
debate.
right, if I just might add, you asked about vaginal estrogen. So when you're using the low-dose things like Vagifem or the creams, you get minimal absorption, so we don't really expect to see a change from that, just improves sexuality perhaps because you have better local changes.
Well, comment on that is I've been a physician for 35 years, and I work New Zealand, Canada, and Oregon, so I'm all over the place. A lot of my patients do say when they stop using their vaginal estrogen, they start having hot flashes and night sweats again. So there must be enough absorption to help with those symptoms. And I see it over and over again. I don't think it's just a coincidence.
I wonder if it's dosing, but Wendy, maybe you could.
Yeah, so I think that there has been a little bit of data looking at ultra.
In the mic, please, Wendy.
Okay, like I came from a session actually because I have seen patients who use vaginal estrogens who complain of nipple tingling when they use it, and supposedly you get more absorption initially, but there may actually be a little bit of systemic absorption because there is a study looking at the ring showing improvement of osteoporosis You know that study where women who use the ring had less or improved bone density after a number of years, which means that you've got to have a little tiny bit of absorption. And so I think that there is an ultra amount that is absorbed, even though we might not be measuring it. It's small, but...
That study was done by Sparoff, and it's the only study that shows that with the very small amount of estrogen absorption, you get that. But I certainly see people, and you think incredulously, you're not getting very much. It's way, way below. And if you look at Vagifem, 17-beta estradiol tablet, and what the absorption is, if patients use it properly for a year, it is minuscule, perhaps as much as a half of a birth control pill, an ultra-low dose one.
Yeah.
But I think that there is absorption in some of these women. And if they're using creams, you know, a 0.625 estrogen cream can be doubled or tripled or quadrupled. And breast cancer patients who have been given this, and we have a large population of this, know that they can control their flushes by increasing their estrogen cream. So unless you have the ring, that's the only thing that really gives you substantial absorption, but I mean, I shouldn't say substantial, gives you some absorption, which is a steady state. And I have seen that as well.
But one tip is we know that the lower you put the estrogen on the vulva, like there is more absorption the higher you put it up in the vagina. So if you put the applicator right up high, close to the cervix, you get more absorption than if you just use a little bit on your finger and put it at the introitus, which often that's all these ladies need.
And it has also been shown that when you have an atrophic vagina, initially when the vagina is more atrophic, then you have a little bit more absorption when you start. And when the vaginal walls replenish, then the absorption is quite lower. So with the different doses that we use, the absorption is less. But tomorrow also there's a symposium on DHEA ovules in the vagina for the vaginal dryness. And the pretension here is that the DHEA acts locally in the cells, which is called intracrinology. And there's absolutely no estrogen nor testosterone in the serum. And that's been measured by very specific methods of calculation. So that can be interesting also to see.
So I just want to make one comment. You know, in our clinic, we prescribe our transdermal estrogen with intermittent progestin. And so we don't have a big prospective randomized controlled trial, but we've been doing it for at least 8 years, and we have hundreds of patients who have utilized this. Because as you get lower with the estrogen dosage, you get less endometrial stimulation, and you require less progestin. And I base this therapy on Bob Casper's work, where he used intermittent progestin. He actually marketed this product in the States, and what he gave was estradiol and the progestin 2 days on, 2 days off. And he wanted to induce the receptors in the breast, give the breast a rest, but he also aimed towards amenorrhea. So what we do is, for instance, with a 25 patch, we might give our progesterone, let's say Monday to Friday, and rest the breast Saturday and Sunday. And so far, I mean, it's not thousands and thousands of patients. We found that a very safe method. Patients like it at all very well. The compliance is good because everybody knows Saturday and Sunday they're not at work. Monday to Friday they use their progesterone. And so the lower you go with your estrogen, the less progesterone you need. And a lot of the endometrial safety data hasn't, for instance, for transdermal, we don't have very much information about exactly how much progesterone and how long you need to give it to really provide excellent protection. So that's just a practical point.
Good information. And
So-
the use of the patch is interesting because you have so many dosages in the patch, 25, 37, 50,
Right.
75. So it gives you a lot of options to use and to
And on the
adapt to.
other side, when we have our patients with POI who are using 100, they need more progesterone. So the question of giving someone who's on 100 just 100 milligrams of progesterone, I do not believe that provides adequate endometrial protection. And if I would give everybody a safety lookout, that it's not the same as a 50 patch with 100 every single day. That's twice as much estrogen, so you need more progesterone to prevent endometrial growth. And I think we need to do that study to see exactly how much progesterone is protective.
But also, you need to look at the obese woman. So even though she may be on Estradot 50 type of patch, she may need 200 milligrams of prometrium if she's on continuous
Right.
combined. But bear in mind that everybody in this room they are doing things that are pretty important and don't have randomized controlled trials. So as you wean patients down, and I was going to try to put somebody in who was 65, who was still having hot flushes, and we know that we want to get them to the lowest dose, and we want to give them at least something that doesn't stimulate their breasts so much. But we have no idea. We don't have any data with regards to this, so we individualize, and maybe I didn't say too much, but I should have put that on the slides. As patients are on hormone therapy, especially as they're on it for longer periods of time, you individualize and see what happens.
I have a question, Elaine. Have you seen, I have some patients whose flashes do not resolve on patches, and when I do their estrogen level, I'm surprised that it's very low. And it seems to me that there are some people who just don't absorb the estrogen through the skin. I'm not there's a few of them, and I don't know why. And have you seen that as well?
I definitely have seen this, and this is an indication to do an E2 level. So the patient continues to have hot flushes with even 75
Right.
to 100. And then you can change them, and they need or they want transdermal. They don't want the oral, and it's very difficult to know what to do with regards to the oral. But if you give oral 17-beta E2, which in Canada is called, oral is estrace, and I think they probably have that everywhere because it's the lowest one. That seems to be absorbed a little bit better, but then if you need the transdermal, or you think that's the best for the patient, what I do finally when I get her to the maximum dose, so she may be taking a 75 patch, but she is getting the equivalent of a 37.5 patch. Right. And so I check her estrogen levels maybe once a year, but you can also tell with regards to her symptoms. And she may just have mild control of her symptoms. Not too many patients, but of course those are the patients that come to the menopause clinic because their family doctors or gynecologists really don't know what to do with them. And I think we all see those patients. Do you find in the audience...
Elaine?
Okay,
I'm sorry to interrupt. You guys have been so patient. I don't want you to miss your coffee break, but the speakers will be here for a couple of minutes if you had questions, and you guys can continue.
Can I just say one clinical pearl with patches? Look at your patient's patch site, because I've had patients who tell me it doesn't work, and they come in, and you say, well, show me your patch site, and she says, oh, well, I took it off when I have a shower, or I went to the gym and I took it off.
yes,
and that's why it doesn't work, because you're not using it. So that's just a clinical pearl.
Thank you, Dr. Roy, and thank you again very much, our speakers.
Oh, my goodness.